Hello, everyone. My name is Presley Willoughby, and today I'll be presenting my summative assessment project. This project walks through the full evidence-based practice process applied to a real clinical case, where I closely analyzed two different intervention approaches. So here's a roadmap of today's presentation. I will begin with the PICO question that guided my evidence search. Then I'll describe the client's background, including his injury details, cognitive communication profile, and school-based needs. Next, I will review both intervention approaches, APT and MSI, providing a theoretical basis as appropriate. I will then summarize the external evidence, where I will briefly highlight the levels of evidence and hello, everyone. My name is Presley Willoughby, and today I'll be presenting my summative assessment project. This project walks through the full evidence-based practice process applied to a real clinical case where I closely analyze two different intervention approaches. So here's a roadmap of today's presentation. I will begin with the PICO question that guided my evidence search. Then I'll describe the client's background, including his injury details, cognitive communication profile, and school-based needs. Next, I will review both intervention approaches, APT and MSI, providing a theoretical basis as appropriate. I will then summarize the external evidence, where I will briefly highlight levels of evidence and major findings from 4 key studies. After discussing the research, I will move on to internal evidence consisting of clinical expertise and client family preferences. And finally, I will integrate all sources of evidence, present the treatment plan I developed, and conclude with an evaluation of the EBP process. So the PICO question that guided this project is, in school-age children with cognitive deficits following moderate traumatic brain injury, does attention process training, or APT, or metacognitive strategy instruction, MSI, result in greater improvements in executive functioning and generalization to academic tasks? This question was designed to directly address the core issue in this case, the student's ability to return to school successfully. Academic reintegration requires not only basic attention, but also higher level processes such as self-monitoring, task planning, and cognitive flexibility. And for this reason, both foundational attention and metacognitive strategy use are relevant, which makes APT and MSI useful interventions to compare head to head. The client is a 13-year-old male currently in 7th grade who sustained a moderate traumatic brain injury during a motor vehicle accident in which he was ejected from the vehicle due to not wearing a seatbelt. He is 3 weeks post-injury and receiving care in an inpatient pediatric rehabilitation unit at a children's hospital. Before his accident, he had no significant medical or developmental history. Academically, he was an average student who excelled in math, though he occasionally needed support with organization. He also played on the school soccer team, demonstrating typical social and extracurricular involvement. He lives in an English-speaking household with his mother, father, and younger sister, and his family is highly supportive and eager to be involved in his recovery. Their engagement is significant because family participation can heavily influence strategy generalization, and overall rehabilitation success. So this is just a little bit more specific information about his moderate TBI diagnosis. At the scene, he had a Glasgow Coma Scale score of 10, placing him in the moderate category. He experienced approximately 15 minutes of loss of consciousness, followed by 24 to 36 hours of post-traumatic amnesia. A CT scan revealed no penetrating injury or major hemorrhage, but it did show diffuse axonal injury, particularly involving the white matter tracts in the frontal lobes. And these regions are crucial for attention regulation, inhibition, initiation, planning, and overall executive control, which are areas this client now shows significant deficits in. So, following his injury, the client now presents with a wide range of deficits across cognitive, motor, and communication domains. Cognitively, he has decreased working memory, difficulty regulating attention, slowed processing speed, and prominent executive functioning deficits, including impaired initiation, inhibition, planning, and task persistence. He also struggles to generalize learned strategies from structured tasks to new or functional contexts, which is particularly concerning for school reentry. Motorically, he demonstrates mild right-sided weakness, coordination challenges, and balance difficulties, along with fine motor impairments that affect his handwriting. These issues will impact his school tasks, such as note-taking or participating in activities that require some more precise coordination. Communication deficits include reduced articulatory precision and decreased respiratory control, resulting in occasional reductions in speech intelligibility, especially when he becomes fatigued. He also exhibits slowed speech rate, word finding difficulties, and mild pragmatic deficits, such as challenges with interpreting nonverbal cues, staying on topic, and managing conversational turn taking. Together, these impairments, especially in attention, processing speed, and executive functioning, present the greatest potential barriers to his classroom participation, academic learning, and everyday independence. Attention process training is a direct restorative cognitive training program that is designed to rebuild attentional capacities through structured hierarchical drills. APT targets sustained, selective, alternating, and divided attention using repetitive tasks that gradually increase in complexity. APT sessions typically occur in highly structured and low distraction environments to help maximize attention to tasks. And the goal of APT is to strengthen underlying attentional systems that support more complex executive functioning. And because this approach focuses on rebuilding foundational cognitive structures, it is often used earlier in TBI recovery. APT is grounded in Solberg and Mateer's hierarchical model of attention, which organizes attention into 5 interconnected levels, which are focused, sustained, selective, alternating, and divided attention. The model proposes that higher level attentional skills depend on mastery of the lower level ones. This hierarchy forms the basis for APT's structured approach, which systematically rebuilds attention from the bottom up. This theoretical foundation supports the idea that improving basic attention can help restore higher order executive functioning, which aligns with the client's needs. Metacognitive strategy instruction takes a very different approach than APT. Rather than attempting to restore cognitive capacity directly, MSI teaches clients how to plan, monitor, and regulate their own behavior during tasks. It incorporates strategies such as self-monitoring, breaking tasks into steps, goal setting, and error checking. Unlike APT, MSI embeds strategy practice within real-world functional tasks, such as organizing school materials, completing assignments, or planning projects. And this makes MSI particularly effective for promoting generalization, which is essential for a student who's returning to school. So adolescents, including this 13-year-old client, are developmentally ready to engage in this sort of reflective thinking and strategy use, making MSI appropriate for this particular client. So starting to look at the external evidence, in the first study I reviewed by Solberg et al. In 2014, the researchers evaluated APT3 in combination with metacognitive strategies and classroom generalization tasks. This level 2A controlled clinical trial included 14 school-aged children with TBI. The intervention combined repetitive attention training with strategy instruction and school-based carryover activities. The results demonstrated significant improvements in sustained and selective attention, better task persistence, and observable improvements in on-task behavior in the classroom. Teachers noted improved academic participation, and parents reported increased independence during homework routines. Although the study supports APT's value, its limitations include the small sample size, lack of randomization, and difficulty isolating the effects of EPT from the strategy components. The results suggest that APT is most effective when combined with the strategy-based interventions. The second APT study from Seguin et al. In 2018 was a level 1B randomized control trial examining the feasibility and cognitive effects of an intensive attention training program in adolescents with moderate to severe TBI. Participants were randomly assigned to either a restorative attention training group or an active comparator group completing cognitive games. This study found significant improvements in working memory, inhibition, and cognitive flexibility among adolescents receiving attention training. These improvements emerged even in early recovery, suggesting that structured attention interventions can harness early neuroplasticity. However, limitations of the study included the small sample size, short-term follow-up, and highly controlled research environment. Nonetheless, this study provides strong evidence that attention-focused interventions can support improvements in both attention and basic executive functions. So after analyzing this research, the studies consistently showed gains in attention regulation, working memory, processing speed, and basic executive functions after structured APT or APT-like training. APT builds the bottom-up capacities that support later strategy use, academic learning, and cognitive stamina, which is especially important early on after moderate TBI. APT alone does not reliably transfer to school tasks or real-life behaviors, and the best outcomes come from APT combined with metacognitive and generalization components. And finally, the evidence supports intensive attention-focused drills for adolescents soon after TBI, when neuroplasticity and structured routines favor more rapid cognitive gains. The first MSI study I examined was Wade et al. From 2011, a level 1B randomized control trial evaluating the effects of counselor-assisted problem solving, or CAPS. This family-centered MSI intervention was delivered via web-based modules combined with therapist coaching. The results showed significant improvements in executive functioning, behavioral regulation, and family communication. These improvements were especially notable for adolescents with more severe impairments, which is similar to the client in this case. Because CAPS embeds strategy use into everyday routines, the intervention strongly supports generalization across home and school settings. Limitations include reliance on parent and self-reported measures, and the fact that academic performance was not directly assessed. Still, the study offers strong evidence for the effectiveness of MSI in adolescents recovering from TBI. And the second MSI study from Brandt et al. In 2021 was a level 1B randomized control trial examining pediatric goal management training, which is one of the most standardized metacognitive executive functioning interventions that's commonly used for children and adolescents with acquired brain injury. The results showed that while both the treatment and control groups improved on parent-rated executive functioning. The GMT group demonstrated significantly greater improvements on inhibition and executive attention tasks. These gains were maintained over time, supported by follow-up data from a later long-term study. Though some limitations included sample heterogeneity and overlapping improvements across groups, the performance-based results strongly support MSI as an effective intervention for executive functioning deficits. And some key takeaways from these pieces of evidence include that the RCTs show significant gains in planning, inhibition, initiation, organization, and self-monitoring, especially when family supported. MSI leads to improved daily functioning, school participation, and behavioral regulation, making it the preferred approach for academic and home routines. Both MSI approaches within the research showed that adolescents can successfully learn and use metacognitive frameworks, improving independence in complex tasks. And the literature demonstrates that caregiver coaching boosts EF recovery, behavior management, and emotional adjustment, which are key factors in school reintegration. So from my clinical experience working with adolescents with TBI in inpatient pediatric rehabilitation, I have consistently seen stronger functional outcomes when treatment emphasizes strategy use and self-monitoring and behavior regulation, which are key components of MSI. MSI can definitely support independence with homework, class participation, and emotional regulation. And these observations align with the external evidence that showed that MSI helps lead meaningful real-life improvements in executive functioning. So the client and his family expressed clear preferences for interventions that are functional, practical, and closely tied to academic and behavioral outcomes. Their primary goals include improving independence, supporting school reintegration, and strengthening emotional and behavioral regulation. The family values being active participants in treatment, and they want to learn how to support the client's strategy use at home. The client himself is frustrated by difficulty staying organized, completing schoolwork, and keeping up with tasks. So bringing together all three components of the EBP model, external evidence supports both APT and MSI, but MSI has stronger evidence for generalization, inhibition, planning, and real-world executive functioning. Clinical expertise indicates that MSI produces the most meaningful school and home-based improvements for adolescents with similar profiles, and client and family preferences strongly favor functional, school-related outcomes and strategy-based interventions. So based on the integration of evidence, I selected metacognitive strategy instruction as the primary treatment approach for this client. Although a combined APT and MSI model is supported, MSI is the best primary treatment choice for this specific client at this stage in his recovery because it best fits his executive functioning deficits, his age and developmental readiness, his goals for academic reintegration, and it had the strongest evidence for functional generalization. So the treatment plan includes teaching the client to use structured strategies such as stop, plan, do, check during academic and functional tasks. Goals focus on increasing independence with homework, improving inhibitory control and task persistence, and applying strategies across different settings. The intervention will be delivered 4 to 5 times per week, one-on-one over a 4 to 6 week period during his inpatient rehabilitation stay. Sessions will incorporate direct strategy instruction along with guided practice that is embedded within different meaningful and functional tasks that are specific for him. And family coaching will also be included to help facilitate this generalization of strategies at home. The expected outcomes include improved executive functioning, increased independence, better academic participation, and enhanced emotional and behavioral self-regulation. So while APT has important benefits, particularly for early cognitive rebuilding, MSI better matches the client's needs, aligns with the family's goals, and has stronger evidence for real-world functional outcomes. MSI directly supports the skills necessary for academic reintegration, such as planning, organization, and behavior regulation. Given this patient's needs, MSI more directly targets the outcomes that matter most to him and his family, which is ultimately the most important thing to focus on. APT could still be incorporated as a supplemental approach, but MSI should be the primary focus of intervention, especially as the client prepares for school reentry. So reflecting on the EBP process, it became clear that each component, the external evidence, internal evidence, including the client preferences and clinical expertise, each played a critical role in shaping the intervention decision. While the research base for pediatric TBI can be limited, the available evidence strongly supports metacognitive and strategy-based interventions for improving everyday functioning. My clinical expertise helped interpret the research within the context of real-world rehabilitation, while the client and family goals guided the selection of approach that was centered more on functional improvements for the client. Throughout this process, I remained mindful of my own potential biases in favor of strategy-based interventions, but overall ensuring that the final decision was consistent with all sources of evidence and taking all evidence into consideration. And overall, this project reinforced the importance of integrating research, clinical judgment, and client-centered care to support a truly effective and individualized treatment plan for this patient. Here are the references that I used throughout my project, and thank you for listening.